So we shall continue with the insulin. We have discussed different short-acting and long-acting insulins and their analogs and what are the advantages of the analogs over the regular insulin or human insulin. Now today we shall start with the discussion of the insulin delivery, how insulin is delivered. So insulin route of administration is subcutaneous commonly, but in emergency cases it can be given intravenously, and most insulin is injected subcutaneously. And there are pen devices containing prefilled regular Lispro, NPH, Glargine, premixed Lispro, Protamine Lispro, or premixed aspart, Protamine aspart. So this premixed Lispro, Protamine Lispro and premixed aspart, Protamine aspart, they will ensure that actually short-acting and long-acting insulin are given in the same syringe or pen to ensure the compliance, because if long-acting and short-acting need to be given separately, often a compliance is an issue, because short-acting insulin commonly given it is twice, 2 to 3 times before meal, and short-acting and long-acting insulin commonly given once or twice daily. So if it need to be given separately, then often patient requires 4 injections per day, and if it is premixed, then that problem of giving 4 injections per day can be minimized, and patient can take 2 injections per day, and that will improve the compliance actually. So jet injector system enables patients to receive subcutaneous insulin injection without a needle, and intravenous infusion of insulin are where this is needed. Patients with ketoacidosis, diabetic ketoacidosis, there is a situation when insulin is very much deficient and patient is having ketosis due to this insulin deficiency. During the perioperative period, it should be given IV. During the labor and delivery, and also in some ICU conditions, patient critically ill, then also insulin infusion should be given IV. So apart from this, the common scenario, we shall give insulin in subcutaneous route, and this is the insulin syringe. It is marking at the unit and not in the milligram, and it is a very tiny needle. You shall see that. So this is suitable for the subcutaneous injection, and it is almost very negligible pain. Another delivery method is this insulin pump, which is important mainly for the patients who are having very fragile control of the diabetes, that means frequent hypoglycemia, frequent hyperglycemia in same patient. Then insulin pump is given. So there is a dosage instruction are entered into the pump's small computer, and the appropriate amount of insulin is then injected into the body in a calculated controlled manner. So this pump senses the presence of the how much is the blood glucose, and accordingly that will deliver the insulin into the patient, so that it can minimize the risk of hypoglycemia as well as hyperglycemia, and it is inserted in the subcutaneous tissue. And if we give insulin by this pump, this method is called continuous subcutaneous insulin infusion. So insulin pumps provide a constant basal infusion of the insulin and option of different infusion rates during the day and night. So it is mainly useful for the type 1 diabetes patient, where we have to combine short-acting and long-acting insulin both, and the short-acting insulin will depend on the amount of the meal patient is taking. Otherwise, there will be hypoglycemia. Or if insulin is less delivered, then it can cause hyperglycemia, and insulin is more delivered, then it will cause hypoglycemia. So if according to meal intake, according to the patient's blood glucose status, there is a sensor in the insulin pump which will give the proper dose to the patient. And bolus injections that are programmed according to the size and nature of the meal. And insulin deficiency and ketosis may develop. Rapid leave therapy is interrupted accordingly, accidentally. So this is a complication of the insulin pump. If it is if the tube is interrupted accidentally, then suddenly insulin deficiency and ketosis may develop. So pump failure, dislodgement of the needle, aggregation of the insulin in the infusion line, accidental kinking of the infusion catheter, these are the complications of the insulin pump. So how a pump works: the insulin is housed inside the pump in a little cartridge called reservoir, and insulin travels into your body through a flexible tube that ends in a tiny needle called the cannula. It is inserted just under the skin. A needle is held in place by an infusion set. A little adhesive patch is stuck on your skin. So these are the different parts of the insulin pump. There is a tubing, there is a cannula which is inserted into the subcutaneous tissue, and there is a display also present in some pumps, so that patients can calculate their insulin daily requirement and amount of insulin which is injected after every meal. And there is insulin reservoir, and of course battery is needed. So this is one method of giving insulin is insulin syringe, it can be insulin syringe. Remember, insulin syringe is two types. One is called U40 and one is called U100, depending on the concentration of the insulin. So U40 syringe in 1 unit indicator, this is the unit indicator. 1 unit 1 ml contains 40 units syringe, 40 units insulin, and U100 needle 1 ml contains 100 unit of insulin. So there is a color, often there is a confusion in the color. Normally we use U40 syringe, the color is orange, and U100 syringe, the color is red. And this is the insulin pen, which is the most convenient device to use. And remember, insulin pen need not be stored in the refrigerator, unlike the insulin syringe, where insulin vial need to be stored in the refrigerator, not in the deep freezer part, but in the refrigerator. And each time patient takes insulin, he has to take out from the refrigerator, he has to make the temperature normal before giving the insulin, and then inject the insulin by the syringe. But insulin pen is devoid of those problems, and it can be carried along with the patient, and in convenient time he can inject it. There is no need of refrigeration, just to avoid the sunlight. So insulin dosing and regimes. So there are multiple doses is present in the insulin, and this can be called as, so there are 4 regimes actually: basal, basal plus, basal bolus, and split mix regime. So commonly when we decide about taking insulin, we are commonly considering the type 2 patients. Type 1 patients require insulin, and that is ideally basal bolus. Now what is this basal, what is basal plus, and what is basal bolus? So when a one time long-acting insulin like glargine is given, that is called basal insulin. So basal insulin means long-acting insulin, which will ensure that insulin supply is present continuously, and that will take care of mainly the fasting hyperglycemia. So when patients are having significant fasting hyperglycemia, basal insulin is given at night commonly to ensure there is fasting hyperglycemia is controlled. If along with that fasting hyperglycemia, if postprandial hyperglycemia is also present, then we go for basal bolus or basal plus. Basal plus means giving one basal insulin or long-acting insulin at night, plus give one short-acting insulin like aspart or lispro before major meal. That is basal plus. If that is also not able to control your sugar, then you have to give this short-acting insulin 3 times before meal. That means 1 time basal and 3 times short-acting insulin or basal bolus insulin. So that is regime is called basal bolus regime, and that is commonly used in type 1 diabetes patient because insulin is completely absent in them. So basal bolus regime is the ideal for the type 1 patient where no oral tablet is actually working. But in type 2 patients where some oral medicines are given, along with that insulin is given, so then basal or basal plus regime is very good for the type 2 patients. So basal insulin is just giving 1 time long-acting insulin. Basal plus means giving 1 long-acting insulin plus short-acting insulin once before major meal, and basal bolus is 1 time insulin, long-acting insulin plus 3 times short-acting insulin before 3 meals. And split mixed means where premixed insulin is given. That means in a single syringe, in short-acting and long-acting insulins are mixed, and that can be given once or twice daily. That is called split mixed regime. So insulin administered as a single daily dose of long-acting insulin alone or in combination with short-acting insulin is rarely sufficient to achieve euglycemia. And more complex regimes that includes multiple injections of long-acting or short-acting insulin are needed to reach this goal. So commonly the split mixed regime is not very much successful in controlling the blood glucose, because short-acting long-acting insulin, though they are combined together, often they fail to control the hypoglycemic attacks. That's why basal bolus or basal plus regime is ideal, though it's costly because basal insulins are commonly costly. And more complex, in all patients, careful monitoring of therapeutic endpoints GLC, insulin dose by self-glucose monitoring, and measurements of the HbA1c. So HbA1c monitoring is very important. Along with that, fasting and PP hyperglycemia should be monitored to adjust the insulin dose. Now in type 1 patients, we know that insulin is the mainstay of therapy. There is no good oral medicine is available. Because insulin is totally deficient, we have to begin insulin from the very beginning. But in type 2 patients, therapy is commonly with the oral drugs, but insulin is needed in some cases. Where they are needed is a very important question, commonly asked in theory as well as viva. So use of insulin in type 2 diabetes patients. When it is not controlled by the diet or exercise, or when these are not practicable, primary or secondary failure of the oral hypoglycemics, or when these drugs are not tolerated. So primary failure of oral hypoglycemics means oral hypoglycemics are given, but patient is showing poor control from the very beginning. That is called primary failure. That then insulin is need to be started from the very early. But secondary failure means patients were well controlled initially with the oral drugs, but after a few years of use, it is not showing good control. Then insulin is need to be started. So this is called secondary failure. So both primary and secondary failure of oral hypoglycemic agents, or when these drugs are not tolerated due to some contraindication or adverse effect, then also insulin is indicated. Underweight patients, insulin is very good choice because insulin is the anabolic hormone, so it increases the body weight, and that's why in type 2 diabetes patient also, if it is they are showing weight loss, then insulin is a very good drug. And temporarily to tide over some critical situations like infections, trauma, surgery, or pregnancy, insulin is drug of choice. In the perioperative period and also during labor, IV insulin infusion is preferable. Any complication of diabetes like ketoacidosis, HHS, that means hyperosmolar hyperglycemic state, and gangrene of the extremities, then insulin is given, is preferred over the oral drugs. And this is the last indication, is very important, that is called fast detection of diabetes. If fasting blood glucose is more than 250, PP blood glucose is more than 350, and HbA1c more than 9%, then also if it has been seen that if you start insulin early, then within 1 or 2 months of the blood glucose comes down to very normal, and then even without insulin, patient can be managed with the oral drugs very good. Well, so that is also indication of the insulin. But most commonly, you shall remember the primary and secondary failure of the oral drugs, and temporarily to tide over infection, surgery, trauma, pregnancy, and also in some critical situations like ketoacidosis, gangrene of extremity, hyperosmolar hyperglycemic state during labor. And this is the last point, that fast detection of diabetes if HbA1c is more than 9% and fasting PP blood glucose is very high, then also insulin initiation very early actually will ensure better control of the blood glucose, and even patient can be insulin can be omitted after 2 to 3 months of use, and oral medicine is very then can be used very satisfactorily. So algorithm for adding or intensifying insulin. So how to start? So basal insulin should be started early. I have mentioned that if we want to start basal insulin in the type 2 diabetes patient, we shall start with the basal insulin or long-acting insulin, that is the glargine or degludec. So if it is HbA1c is less than 8%, so then insulin dose is to its initial dose is 0.1 to 0.2 units per kg. If it is HbA1c is more than 8%, then daily dose is 0.2 to 0.3 unit per kg. But gradually we have to increase the dose as per or decrease the dose as per the patient's response. Our target of fasting blood glucose is less than 130, and target of postprandial is less than 180. So if it is fasting is more than 140 or more than 180 suppose, then we gradually increase the insulin dose. But initial dose is 0.1 to 0.2 unit per kg or 0.2 to 0.3 unit per kg. And then after initiation we have to intensify the therapy, and we can intensify with the therapy with by adding the GLP-1 receptor agonist, SGLT2 inhibitor, other drugs like. Okay, so if fasting blood glucose after initiation, if fasting blood glucose is suppose it is 140 to 160, then we add plus 2 units of insulin at the night, long-acting insulin. And if it is fasting blood glucose more than 180, then we can add 4 units accordingly. If fasting blood glucose is less than 90, then we can decrease the dose by 2 units. So likely according to the fasting blood glucose level, we can increase or decrease the dose of insulin, and we have to intensify the therapy gradually. If postprandial hyperglycemia is not controlled, then we can add one short-acting insulin before the major meal. And why this initiation of insulin is important in type 2 diabetes also? So this is called legacy effect or metabolic memory. So early to achieve rapid control of blood glucose, it has been shown that it leads to delayed or less development of the chronic complications like nephropathy, neuropathy, retinopathy. So these three are the very common. Actually, if diabetes is continued life for a long time, these complications will bound to happen. So nephropathy, neuropathy, retinopathy, these three complications is likely to be delayed if initial control of the blood glucose is satisfactory. So if patient's blood glucose is very high, suppose 300 fasting, 400 pp, initial therapy with insulin for few days will decrease the blood glucose significantly, and that will delay actually this initiation of the progression of this disease, these complications. So that's why initial therapy with insulin is very important in type 2, where it is very much blood glucose is very much raised during the diagnosis. So all these are good for the insulins, but what are the adverse effects? It can cause hypoglycemia definitely, and it is more common with the regular insulin. With analog insulin it is less, but often with high dose it can happen. Modest weight gain can happen. So in obese patient with type 2 diabetes, insulin is often delayed because of risk of the weight gain. Deterioration of retinopathy and atrophy of the subcutaneous fat at the site of insulin injection, or this is called lipoatrophy. So it is advised to prevent the lipoatrophy, insulin injection that is given subcutaneously at the umbilical and the periumbilical area in the abdomen. So sites should be changed. In one day it should be given in the right side, one day it should be in the left side, and one day it can be given just above that area of the initial on the day 1. So accordingly there are 4 or 5 sites, so we can change the therapy, change the injection sites, and that will prevent the lipoatrophy. So lipohypertrophy will occur if injection is repeated on the same site day after day, and that will actually reduce the insulin dosing also, because the lipohypertrophy or hypertrophy means insulin is stored in a same site, and that will actually slow down the absorption further. So that's why it is very important to change your injection site and to prevent lipoatrophy. And also it can cause some allergic reaction that was actually common with the previous insulins like bovine or porcine insulin, but less common with these analogs or human insulin. So hypoglycemia, weight gain, deterioration of retinopathy, and lipoatrophy, lipohypertrophy, these are the adverse effects of the insulin you must take aware of. So after insulin, we have to discuss oral antidiabetic agents. So there are multiple oral antidiabetic agents, and they each have some unique property. We have to know it in detail. Sulfonylurea, first generation and second generation. Tolbutamide and chlorpropamide for first generation. Second generation name starts with the G. So glibenclamide, lipizide, gliclazide, glimepiride. These are the second generation sulfonylurea. Okay, and actually the first generation sulfonylurea, they are actually short acting, and second generation sulfonylurea are longer acting. And due to this longer acting, they can be given once daily commonly, can be given twice daily sometimes. But first generation sulfonylurea need to be given 3 or 4 times a day. And also first generation sulfonylurea are more prone to cause hypoglycemia. So that's why second generation sulfonylurea are now commonly used, like glimepiride or gliclazide, which is having relatively less risk of hypoglycemia. Next, biguanides, metformin. So actually metformin is the first anti-diabetic drug to be used for all stages of diabetes. So though sulfonylurea came into use first, but metformin is must for all the patients unless it is contraindicated in some renal impairment cases or lactic acidosis. So metformin is the mainstay of therapy of diabetes, remember that, type 2 diabetes. Next, meglitinide analog like repaglinide, nataglinide, thiazolidinediones. So this is a tongue twister. Thiazolidinediones, example is pioglitazone. Previously there was another drug like rosiglitazone. Rosiglitazone is now banned due to cardiotoxicity. The incidence of myocardial infarction was high with them, due to that. Rosiglitazone is now banned, only pioglitazone remains. Next, alpha glucosidase inhibitors like acarbose, voglibose, meglitol. DPP4 inhibitors like sitagliptin, linagliptin, vildagliptin, teneligliptin, and SGLT2 inhibitors, canagliflozin, dapagliflozin, empagliflozin. So these are the 7 major drug groups, oral antidiabetic drugs. We have discussed insulin, that is injectable, and the oral, sulfonylurea, first generation, second generation. Remember the second generation mainly, glimepiride, gliclazide are more commonly used. Metformin, next repaglinide, nataglinide, there are the meglitinide analog. Next, thiazolidinediones is pioglitazone, alpha glucosidase inhibitor like acarbose, voglibose, DPP4 inhibitor like sitagliptin, vildagliptin, and latest addition is SGLT2 inhibitors like canagliflozin, dapagliflozin, empagliflozin. So one by one we shall discuss each drug. So sulfonylurea, I think mechanism of action have been covered in during discussion of insulin. They act on the beta cell, and they act on the ACUR1 receptor on the pancreatic beta cell membrane. They cause depolarization by reducing the conductance of the ATP sensitive potassium channel. So ACUR1 is one kind of orphan receptor. So when sulfonylurea drug is given, they bind to the ACUR1 and that will depolarize the beta cell, and after this depolarization there is how they depolarize the beta cell, they cause inhibition of this ATP sensitive potassium channel, and due to this depolarization there is increased influx of the calcium and there is release of the stored insulin. So this by degranulation. So the rate of insulin secretion at any glucose concentration is increased. So whatever be the glucose concentration in the body, sulfonylurea introduction will cause enhanced insulin release, and that's why there is hypoglycemia. So when glucose level in the patient's blood is low, even then sulfonylurea cause enhanced insulin release, and that will increase the chance of hypoglycemia. Okay, and minor reaction is also there that reduce the glucagon secretion, and they also sensitize the target tissue to the action of the insulin and increase the number of insulin receptors, and there is a post receptor action also. So apart from the insulin release enhancing action, they also sensitize the target tissue to the action of the insulin, and they increase the number of the insulin receptors. So they help in the insulin action also. So all sulfonylureas are well absorbed orally, and 90% or more are bound to the plasma proteins, low volume of distribution, 0.2 to 0.4 liter per kg because of their high plasma protein binding, and also their half-life are short. Their hypoglycemic effects are evident for 12 to 24 hours, and that can be and most of the sulfonylurea nowadays, like glimepiride, glycoside, that can be given once daily, but sometimes can be given twice daily if the blood glucose control is poor. So this, remember, this hypoglycemic effects are evident for the 12 to 24 hours. So it is being said that hypoglycemia due to insulin is common. Hypoglycemia sulfonylurea is also common, but hypoglycemia due to insulin is easier to treat. But hypoglycemia due to sulfonylurea is actually difficult to treat because their hypoglycemia can last for 24 hours. So whereas hypoglycemia due to insulin, they are mostly happening due to short-acting insulin whose action lasts maximum for the 3 to 4 hours, and that's why hypoglycemia is can be easily corrected. But sulfonylurea-induced hypoglycemia can be recurrent and difficult to manage. Drug interactions. So drugs that enhance sulfonylurea actions by displacing protein binding like sulfenpyrazone, salicylate, sulfonamide, they cause hypoglycemia. We have discussed the NSAID and sulfonylurea drug interaction during the NSAID class. So salicylate is also NSAID, and salicylate that can displace the sulfonylurea from their protein binding site, thus can cause hypoglycemia. Cimetidine, warfarin, chloramphenicol that can inhibit sulfonylurea metabolism, thus they can also cause hypoglycemia. And salicylate, propranolol, beta-lytics, they also prolong their pharmacodynamic action, can cause hypoglycemia. So adverse effect, hypoglycemia is the predominant side effects, and that can be occasionally severe and rarely fatal, and more commonly in elderly, especially patients of liver and kidney disease. We have to be very cautious about the dosing because in liver and kidney disease patients they are more prone to have hypoglycemia. Chlorpromamide, that is a first generation sulfonylurea. Chlorpromamide, it is a frequent culprit due to its long action. Tolbutamide carries the lowest risk due to its low potency and short duration of action. But tolbutamide problem was that tolbutamide was need to be given repeatedly because of its short duration of action. And among the second generation, gliclazide, glimepiride, glipizide, they are having, it is not glipizide, gliclazide, that they are having low incidence of the sulfonylurea, hypoglycemia. And apart from that, there can be hypersensitivity reaction because it is sulfonylurea, so it contains sulfur moiety. So sulfur drug allergy patients they can rarely have some photosensitivity rashes, and rarely it can cause aganorocytosis, leukopenia, etc. Chlorpromamide in addition can cause hyponatremia, cholestatic jaundice, and it should be avoided in pregnant and lactating women. So sulfonylurea is not a good choice in pregnant and lactating women, but among them glibenclamide was used in pregnancy when the blood glucose is not very controlled. But remember, in pregnancy, metformin and insulin, they are the drugs to be used, not sulfonylurea. So these are all for the sulfonylurea. Remember the two generations, common adverse effect and mechanism of action. Next, very important is metformin. That is chemically it is a biguanide, and it is AMP kinase and PPAR gamma AMP kinase activator. So it is the only member of the bioguanide class, and it causes little or no hypoglycemia in non-diabetic subjects. So sulfonylurea acts by enhancing the insulin release and also enhancing the insulin receptor so that insulin can act better. But metformin do not have the secretory effect. They only increase the insulin sensitivity so that liver glucose production is decreased. Muscle and adipose tissue will take up the majority of the glucose. So they have no little or hypoglycemia. As there is no secretory effect of insulin, there is no hypoglycemia. So remember, all anti-diabetic drugs are not hypoglycemic. So hypoglycemia will be caused when insulin release is or insulin action is enhanced. Insulin release is enhanced mainly. So mainly sulfonylurea can cause hypoglycemia, and also rarely GLP-1 analog can cause hypoglycemia, and rapaglinide, netaglinide, the meglitine analogs also they increase insulin release, they can cause hypoglycemia. Apart from insulin, of course, insulin can cause hypoglycemia, but other drugs like metformin, DPP-4 inhibitor, SGLT2 inhibitor, pioglitazone, they do not cause hypoglycemia because they do not increase the insulin release. So in diabetics also, episodes of hypoglycemia due to metformin are rare and improves the lipid profile as well in type 2 diabetes patient. So what is the mechanism of action of insulin? Metformin, they stimulate the AMP-dependent protein kinase, and AMP kinase is activated by the phosphorylation when cellular energy stores are reduced. So when cellular energy store is reduced, AMP kinase is activated by phosphorylation, and this stimulates fatty acid oxidation, and this stimulates the glucose uptake by different tissues like mostly skeletal muscle and adipose tissue, and this reduces the lipogenesis and gluconeogenesis. So in liver, gluconeogenesis is also inhibited due to this AMP kinase activation. So net results are increased glycogen storage in the skeletal muscle, lower rates of hepatic glucose production, insulin sensitivity is enhanced, and there is ultimate result is low blood glucose level because most of the blood glucose is now uptaken by the tissues. And these inhibit the cellular proliferation by specific action on the mitochondrial complex 1. And as it do not cause hypoglycemia, so there is no effect on the blood glucose in the normoglycemic states and does not affect the release of insulin. So in normoglycemic patients also, metformin is not harmful, but in normoglycemic patients, sulfonylurea is very harmful because it can cause significant hypoglycemia. Pharmacokinetic, it is absorbed primarily from the small intestine and excreted unchanged in the urine, does not bind to plasma proteins. T-half is 2 hours, but commonly it is given 2 to 3 times daily. Transport of metformin into cell like hepatocyte myocytes is mediated by organic cation transporter. So this is the metformin, and it is currently the most commonly used oral agent to treat the type 2 diabetes, generally accepted as a first line treatment for type 2 diabetes. So all guidelines, metformin is the first choice, and it will also reduce the cardiovascular events in the type 2 diabetes patient. It is effective as a monotherapy and combination therapy with nearly every other therapy for type 2 diabetes. Treatment is started with low dose and titrated over days 2 weeks to minimize the side effects. So currently recommended dose is, we shall start with 500 to 1 milligram to 1 gram twice daily, and with maximum dose of 2550 milligram. Okay. So commonly we shall start with 500 milligram to 1 gram twice daily with a maximum dose of 2.55 gram. What are the adverse effects? Adverse effect is gastrointestinal. 10 to 25% patients will report nausea, indigestion, abdominal cramps, diarrhea, and it reduces the vitamin B12 absorption. So there is lower blood level of the vitamin B12 due to malabsorption. So chronic use of the metformin, patients will have vitamin B12 deficiency. That's why supplementation of vitamin B12 is essential while patients is on metformin. Lactic acidosis is rare, but not very. It is reported. It is reported in patients with sepsis, MI, or heart failure, and also in liver failure patients it is called lactic acidosis. So lactic acidosis is a risk factor for metformin use. Previously, there was another biguanide that is called fenformin. It is very much prone to cause lactic acidosis. That's why it is now banned. But metformin, no very negligible risk, but in patients of sepsis, MI, heart failure, this should be avoided because it can cause lactic acidosis. And renal failure is a relative contraindication. In renal failure patient, it is now stated that metformin should be used. Should not be used below eGFR of 30%, and its dose should be reduced if eGFR is below 45%. So eGFR below 30%, metformin should be contraindicated and should not be used, and eGFR below 45%, it should not be introduced, but if it is continued, dose should be reduced. So apart from diabetes, metformin is also used in treatment of the Polycystic ovary disease who wants conception. So during conception or when patients want pregnancy in polycystic ovary disease, metformin helps. So that is a very important use of the metformin. And also in NICE guideline in England, as per the European NICE guideline, metformin is also indicated in the pre-diabetes patients also. That means that phase. That means when either there is impaired fasting glucose or impaired glucose tolerance. What is impaired fasting glucose? When blood glucose is 100 to 125 milligram per DL fasting, or EP between 140 to 199. If it is present along with overweight, patient is not able to achieve the normoglycemia after lifestyle modification also, then also metformin is given in pre-diabetes patients. In as per the NICE guideline, in Indian guideline it is not so far accepted, but it can be used. Okay. Next, thiazolidinediones, glitazones. In short, it is called glitazones. Nowadays, so presently it is now only a single glitazone is used, that is pioglitazone. Rosiglitazone is banned due to cardiotoxicity. So this is just insulin sensitizer once again. So they did not promote the insulin secretion from the beta cells, and they actually also, just like metformin action, they increase the insulin sensitivity. So in liver, you see this picture, in liver they reduce the glucose release, hepatic glucose output is reduced. In adipose tissue also there is decreased FFA release. There is decreased free fatty acid release, so liver they inhibit the lipolysis actually. So they cause more fat deposition in the adipose tissue, but they reduce the lipolysis, so free fatty acid release from the adipose tissue is minimized, and that's why there is chance of weight gain because of this inhibition of the lipolysis. More fat deposition in the adipose tissue, there is chance of weight gain. There is impaired glucose uptake in the muscle, which can be increased by this thiazolidinedione and bioguanide. So they increase the glucose uptake into the muscle. Also in pancreas, they increase the insulin secretococcus increase the insulin release, but thiazolidinedione have no role. Okay, so these are the actions of the thiazolidinedione. So mechanism of action, it activates the receptor, that is a big name. That is called paroxysmal proliferator activated receptor gamma, and agonist binding to PPR gamma result in increased insulin sensitivity in adipocytes, hepatocytes and skeletal muscle. They reduce the hepatic glucose production and increase the hepatic glucose uptake. So remember this PPAR gamma activation, there is activation of the paroxysmal proliferator activated receptor gamma. There is agonist binding to PPAR gamma results in increased insulin sensitivity, adipocytes, hepatocytes and skeletal muscle. So net result is increased insulin glucose uptake into these cells. Adipocytes, hepatocytes, skeletal muscle, there is improved glucose uptake but reduced hepatic output from the liver. So they reduce the plasma levels of fatty acids by increasing the clearance and reducing the lipolysis. So as a result, there is improvement in hyperglycemia, improvement in the hypertriglyceridemia, and elevated HbA1c, all are improved. HDL levels are also enhanced. So PPI gamma agonist effect, so decreased free fatty acid, improved insulin action, decreased glucose production, and increased beta cell mass, insulin secretion is also enhanced, inhibition of the lipolysis. And these are the effects of the pioglitazone or thiazolidinedione. Effects of the pioglitazone: so in the liver, decreased glucose output, in muscle, increased glucose uptake, adipose tissue also increased glucose uptake, and also decreased fatty acid release. Cause the shift of the triglyceride source from non-adipose to adipose tissue and from visceral to subcutaneous fat tissue. Therapeutic use: dose is 15 to 30 mg per day, maximum is 45 mg daily, and it is effective as monotherapy, but now commonly it is combined with the metformin or other sulfonylurea or insulin in type 2 diabetes patient. So pioglitazone is the important drug, but adverse effects, it has some adverse effects like weight gain and edema. And insulin and pioglitazone, if it is given together in a patient, that will increase the weight gain risk of weight gain very significantly. It has increased incidence of the congestive heart failure. It can promote the fluid retention. That's why in heart failure patient, pioglitazone is contraindicated, and it is due to other effects of the PPAR gamma, not due to its hyperglycemic effect. So PPAR gamma activation, that will tend to cause fluid retention. There is a macular edema in the eye, and also there is a weakening of the bone. There is increased osteoclast activity with action of the PPAR gamma activation, and there is osteoporosis. So osteoporosis, weight gain, congestive heart failure, these are the adverse effects of the pioglitazone. And rosiglitazone, additionally, it can cause myocardial infarction significantly, and that's why it is banned. But remember, pioglitazone So practically increase the risk of bone fracture in women. It is small but inconsistent reduction in hematocrit attributed to hemodilation due to plasma volume expansion. So as there is volume expansion, there is hemodilation. So hematocrit may be low. And in patients of hepatic failure, it is also contraindicated. And there is around in 2013, it was a hypothesis that pioglitazone may cause bladder cancer. So it was temporarily withdrawn, but because of its very good efficacy and it is very low cost, it has been reintroduced again. The association of increased risk of bladder cancer with pioglitazone was there, but it is important only when it is continued for more than 25 to 30 years. Before that, it is not going to cause any harm, and that too in high dose. So if it is dosed between 15 milligram per day, within 15 milligram per day, and it can be continued lifelong. So there is harm only when it is given 30 milligram per day or more dose for 20 to 25 years, then only it has been shown to increase the risk of the urinary bladder cancer. Otherwise, it is safe. But remember, before giving pioglitazone, always check whether patient is having heart failure or not, whether patient is having osteoporosis or not. If these are present, we should avoid this drug. But it is very good drug because it has no hypoglycemia risk, once again just like metformin. Next, potassium ATP channel modulators like non-sulfonylurea. So we have discussed sulfonylurea, which by acting on the SU1 receptor will inhibit the ATP sensitive potassium channel and thus cause depolarization of the pancreatic beta cell. There are other drugs which act by same manner but not acting on the SU1 receptor. These are called non-sulfonylurea like repaglinine, atteglinine. So these agents bind to the ATP sensitive potassium channels like sulfonylurea and acting in a similar fashion like sulfonylurea to promote insulin secretion. So once again they cause this inhibition of the ATP sensitive potassium channel and cause depolarization of the beta cell. Thus there is calcium influx and ultimately stored insulin is released. Onset and duration of action are shorter and particularly effective at mimicking the prandial and postprandial release of the insulin. Used in combination, they produce better control than any monotherapy. They reach effective plasma levels when taken 30 to 30 minutes before meals. This is metabolized to inactive products by CYP3A4 and excreted in bile. So the drugs that inhibit the CYP3A4 like ketoconazole, erythromycin, they prolong the duration of effect. And at first effect, it can cause hypoglycemia, but it is less than the sulfonylurea because it is very short acting. So they reach effective plasma levels when taken 10 to 30 minutes before meals. So it is given commonly before lunch or dinner, and just to take care of the postprandial hyperglycemia. And after that, it will not cause any lowering in the blood glucose. So it is particularly effective in mimicking the prandial and postprandial release of the insulin. And it is very good drug in the patients of the renal failure also because it is not renally excreted. Next group of drug is alpha glucosidase inhibitor. So this enzyme alpha glucosidase is hydrolyzes the oligosaccharides to monosaccharides which are then absorbed. So these are the sites of action of the acarbose, that is one alpha glucosidase inhibitor. So there are multiple enzymes like maltase, isomaltase, glucoamylase which degrade the starch, and sucrose is also degraded by sucrase. So before absorption of these complex carbohydrates, so this enzyme hydrolyzes oligosaccharides to monosaccharides which are then absorbed. So it is carbohydrates absorbed as the monosaccharide form, and alpha glucosidase inhibition leads to less absorption of the oligosaccharides. So postprandial plasma glucose level ultimately falls. So oligosaccharides are not absorbed or not broken down, so that is not absorbed. So that's why carbohydrate is not absorbed as monosaccharide form. So glucose supply delivered to the blood is decreased. So that's why there is decrease in the postprandial plasma glucose level is decreased, and thus they are used only when the patient is having significant postprandial hyperglycemia. That's why it is very good drug in the Indian subcontinent where carbohydrate is the predominant source of energy, predominant source of our meal. So when the predominant portion of the meal is carbohydrate, then there is chance of IPP hyperglycemia as happens in the Indian patients. So there acarbose, voglibose is a very good drug to control the postprandial hyperglycemia because of their inhibition of the oligosaccharides absorption. So mechanism of action is they delay the carbohydrate digestion by competitively inhibiting the alpha glucosidase with a membrane bound enzyme of the intestinal water, and it is acarbose and voglibose are poorly absorbed remaining in the intestinal lumen. So they are not absorbed, they remain in the intestinal lumen and from the intestine they act and they inhibit the absorption of the monosaccharide. That's why it should be given taken with the meals, because only when there is meal they act. Otherwise, if it is given in empty stomach or just even after meal, it is not going to act act well. So it should be taken with meals. And then first of all, due to accumulation of this oligosaccharide or polysaccharides in the intestine, these are fermented by the intestinal bacteria. So there is increased gas production, and that can cause flatulence, diarrhea, cramping. So this is the adverse effect of the carbos, but actually this adverse effect indicates that these drugs are actually acting. Without this adverse effect, probably patient is not taking the drug at the proper time, and that's why these are not going to be effective. So adverse effects occurrence like flatulence, diarrhea, cramping, that means patient is taking the following the proper advice, and as the drugs are active, so that's why there is accumulation of the polysaccharide and oligosaccharide in the intestine, which is degraded by the intestinal bacteria, and there is fermentation of these saccharides into the, and there is formation of the excess gas. So these are the actually older agents: alpha glucosidase inhibitors, DPP4, pioglitazone, repaglin, reticulinide, metformin, and sulfonylurea. Next, we have to discuss 3 newer agents. One of them is, so before discussing DPP4 inhibitors, that is an oral agent, we have to discuss something about GLP-1 based agents. GLP-1 based agents are injectable. So GLP-1, what is GLP-1? Glucose-like intestinal polypeptide. GLP-1 is glucagon-like peptide 1. GIP is there. GIP is glucagon-like intestinal polypeptide. So incretins, these are called GLP and GIP. So glucagon-like peptide and glucagon-like intestinal polypeptide. These are the 2 incretins. And incretins are GI hormones that are released after meals and stimulate insulin secretion. So while discussing the insulin secretion, we have discussed incretins. And incretins are released from the intestine when there is meal. So incretins are GI hormones that are released after meals and stimulate the insulin secretion by acting on the GPCR, G-protein receptor present on the pancreatic beta cell. So the 2 best known incretins are GLP-1 and GIP, that is glucose dependent glucagon-like intestinal polypeptide. So only GLP-1 are effective for stimulating the insulin release and lowering the blood glucose in persons with type 2 diabetes. So both GLP-1 and glucagon are products derived from the pre-pro-glucagon. So just like insulin, as it is derived from the pre-pro-insulin, there is also this GLP-1 and glucagon are derived from the pre-pro-glucagon. And from where these incretins are secreted? The intestinal L cells. And specific hindbrain neurons process the pro-glucagon into a large N-terminal peptide that includes glucagon or GLP-1 or GLP-2. So intestinal L cells secrete this glucagon or GLP-1, and both GLP-1 and glucagon are products derived from the pre-pro-glucagon. So intestinal L cells are the major source of these incretins. So what is the effect of incretins given intravenously to diabetic patients? In supraphysiologic amount, GLP-1, that is the glucagon-like peptide 1, stimulates insulin secretion. They also inhibit the glucagon release. They delay the gastric emptying. That is a major effect. Delay gastric emptying means patients having satiety early. So he cannot take the meal which he taken previously. So they delay the gastric emptying. They reduce the food intake as a result, and then that normalizes the fasting and postprandial insulin secretion. So the insulinotropic effect of GLP-1 is glucose dependent. That is in contrast with the sulfonylurea. So remember, listen carefully. So sulfonylurea release the insulin independent of their glucose level in the blood. That means even if blood glucose is low, sulfonylurea introduction will cause enhanced insulin release, and that can often increase the risk of hypoglycemia. But GLP-1 receptor, though they increase insulin release, but as this is incretin effect, depending on the meal intake, that insulin secretion varies. So this insulinotropic effect of GLP-1 is glucose dependent. So glucose dependent or meal dependent, so according to the level of the blood glucose or according to the amount of the meal patient has taken, that GLP-1 analog will increase the insulin release. So there is less risk of hypoglycemia, because if blood glucose is low or meal intake is low, insulin release will also be low. But if blood glucose is high, insulin release will also be high. So that's why this is insulinotropic effect is glucose dependent. Then that is the major advantage over insulin. because insulin or sulfonylurea can cause hypoglycemia, but GLP-1 based agent, they do not cause hypoglycemia because of their meal dependent or glucose dependent insulin release. So GLP-1 is rapidly inactivated by one enzyme that is called dipeptidyl peptidase 4, DPP4, and because GLP-1, that's why GLP-1, which is present in our body, that is secreted from the L cells, that GLP-1 has a half-life of only 1 to 2 minutes because it is rapidly degraded by DPP4 inhibitor. So how can we increase the GLP-1 effect? Either by inhibiting the DPP4 enzyme so that GLP-1 effects can last longer, so that insulinotropic effect will last longer, so that insulin release is enhanced. And we can make some analogs of GLP-1 which is not degraded by the DPP4. So these are the major two approach by which we can increase the GLP-1 effects. Either we can inhibit the DPP4 enzyme, which inhibits degrades the GLP-1, or we can make some GLP-1 analogs which is not degraded by the DPP4 enzyme. Okay, understand? So incretins in glucose homeostasis and negative activity of DPP4. So what is the effect of the DPP4 inhibitor? DPP4 inhibitor will enhance the GLP-1 release, GLP-1 action by inhibiting their degradation. DPP4 is dipeptidyl peptidase 4, and there is, so look here, GLP-1 based agent, there is glucose dependent increased insulin from the beta cell and glucose dependent decreased glucagon from the alpha cell, and DPP4 enzyme will cause inactivation of the GLP-1, inactivation of the GIP, another incretin, and as a result of this insulin release, there is increased glucose uptake by the peripheral tissue, and also due to decreased glucagon release, there is decreased glucose production by the liver, and net result is decreased blood glucose. So this is the effect of the DPP4 inhibitor. So they not only decrease the blood glucose, decrease the degradation of the GLP-1 by inhibiting the DPP4 enzyme. They also decrease the glucagon release also, and decrease the glucagon release also decrease the glucose production by the liver, and increase insulin release will take care of the postprandial blood glucose level, and there is increased glucose uptake by the peripheral tissue. So net result is blood glucose decrease. So two broad strategies I have discussed: development of the injectable DPP4 resistant peptide agonist of the GLP-1 receptor, that means the GLP-1 analog which is not degraded by the DPP4 enzyme, or creation of the small molecule of inhibitor of the DPP4. So inhibitor of the DPP4, what are those? Very important weapon in our diabetes practice, that is sitagliptin, saxagliptin, vildagliptin, linagliptin, teneligliptin. So these are the DPP4 inhibitors. These are oral agents. But GLP-1 analogs, that are injectable agents. So GLP-1 analogs, remember, so they are GLP-1 and they are not degraded by the DPP4 enzyme. That's why they are active. Otherwise, if GLP-1 is degraded by the DPP4 inhibitor, DPP4 enzyme, then they are not active, or very short acting actually. So GLP-1 agonists, they are not degraded by DPP4, and as a result of that, they can have enhanced effect of insulin release. Exenatide, albiglutide, litaglutide, lixisenatide, dulaglutide is also newer addition. So this exenatide was the first agent. Albiglutide, litaglutide, dulaglutide, these are the agents of GLP-1 analogs, and these are not degraded by the DPP4 inhibitor. And DPP4 inhibitors, that will decrease the insulin, that will prevent the degradation of the GLP-1, because GLP-1 has a half-life of only 1 to 2 minutes. So sitagliptin, saxagliptin, vildagliptin, linagliptin, teneligliptin, they will inhibit the degradation of the GLP-1. Thus, endogenous GLP-1 will have prolonged effect, and this GLP-1 agonist will have exogenous, that be given exogenously, and that will have the similar action of the GLP-1 because they are not inhibited by the DPP4. So role of a DPP4, it is an extra enzyme located on the luminal side of the capillary endothelial cell, and they are metabolize the incretins GLP-1 by removing the two N-terminal peptides. And tryptophan or DPP4 inhibitor increase the concentration of intact GLP-1 and GIP. So what are the GLP receptor agonists? It is exenatide, synthetic exendin 4. It is approved for use as monotherapy and as adjunctive therapy in type 2 diabetes patients not achieving glycemic targets with the combination of metformin and sulfonylurea. So GLP-1 receptor mechanism, GLP receptor agonist, there is exenatide, and GLP-1 analogs is those albiglutide, dulaglutide. So these are GLP-1 receptor agonist, means they will stimulate the GLP-1 receptor. So exenatide, okay. So they are associated with improved glycemic control as reflected and as in 1% decrease in the GHB1C and weight loss of 2.5 to 4 kg. So why there is weight loss? That is due to this weight. So this is also injectable. So another injectable insulin, they cause weight gain because of their anabolic effect. But GLP-1 and receptor agonist or GLP-1 analog, they will cause weight loss because of their central effect as well as incretin effect. So incretin effect there of this incretin, they increase the satiety. That means they decrease the gastric emptying. So they as they decrease the delay the gastric emptying, there is increased satiety. Patients take less food to and they feel less hungry, and this is a central effect also. So this improved satiety, increased satiety will cause actually decreased weight loss. So patient will take less food because of this GLP-1 receptor agonist or GLP-1 analog. Exenatide is given subcutaneously twice daily, typically before meal. Commonly they are used to control the postprandial hyperglycemia, but newer agents that can be given with much less interval, much less frequently, like albuterol glutarate that can be given once per week, and that will take care of both fasting as well as postprandial hyperglycemia. Liraglutide is given subcutaneous injection once daily. So these are the different GLP-1 analogs. So remember this liraglutide, exenatide, albuterol glutarate. So look here, half-life of the albuterol glutarate is much longer, 5 days. So that's why they need to be given once per week. And these are the dosing. No, dosing need not you remember, but remember this extra long effect of the albuterol and dulaglutide. Renal elimination is present with exenatide. That's why in renal failure patient it is contraindicated, but other GLP-1 analogs that can be given with in renal failure patient also. And all will cause weight loss, but mostly it is seen by the liraglutide mostly, and that's why liraglutide is also a drug of obesity. Okay, so liraglutide, because of their enhanced satiety, because of decreased gastric emptying, liraglutide can be used as in a treatment as a weapon of obesity also in normal glycemic patient also. In non-diabetic obese patient, liraglutide is a very good choice, and of course in obese diabetic patient, GLP-1 analogs are very good choice because they do not cause hypoglycemia. That is an advantage because they do not because they release insulin depending on the meal intake by the patient or depending on the glucose present level present in the patient. And so what are the advantages of GLP-1 analog over insulin? They cause less hypoglycemia or negligible hypoglycemia, and they cause weight loss. That is very important for the type 2 diabetes patient, because in type 2 diabetes patient most patients are obese. Okay, so GLP-1 insulin, weight gain and hypoglycemia, the two major adverse effects, it is not present in the GLP-1 analog. Actually these are reversed. So weight loss and no hypoglycemia is the advantage of the GLP-1 analog. Albuglutide, it is a 97% homology to native GLP-1. It is 2 copies of modified GLP-1 is fused to human albumin, and it is manufactured by the recombinant DNA technology. We have half-life of 3.6 to 6.8 days. So remember, just it is albumin is attached. Dulaglutide is a recombinant GLP-1 Fc fusion protein linking GLP-1 analog to a human IgG4 Fc fragment. So this detail is not required. Just remember this name, albuglutide dulaglutide, because of the so albuglutide, as per the name, it is attached to albumin. Dulaglutide is attached to the Fc fusion protein linking GLP-1 analog to a human IgG4 Fc fragment, and both of them have longer half-life. And what are the DPP-4 inhibitors? This sitagliptin, saxagliptin, linagliptin, vildagliptin, etc. These are the gliptins are DPP-4 inhibitors, and this glutide is GLP-1 analogs. Newer GLP-1 analog, that is semaglutide, it is soon coming to the market. Semaglutide, it has been believed that it will be marketed both as oral as well as injectable form. So all these agents like albuglutide, dulaglutide, they are all injectable subcutaneous agents. But semaglutide, if it will come as both injectable as well as oral form. DPP-4 inhibitors all are given orally, and they cause the enhanced GLP-1 action by inhibiting the DPP-4 enzyme. Advantage is that no hypoglycemia, there is weight neutral, no weight loss is seen like GLP-1 analog, but it is weight neutral, It is well tolerated, no adverse effects almost, though in pancreatitis patient it should be avoided because it can cause pancreatitis. And oral, it is given commonly oral once daily, but vildagliptin need to be given twice daily. Occasional reports of urticaria angioedema, and there is increased heart failure risk with sitagliptin, that's why it is avoided. The characteristic DPP4 inhibitors, sitagliptin, saxagliptin, linagliptin, alogliptin. So these are the doses. And route of metabolism, linagliptin, look here, not extensively metabolized. That's why in liver failure patient, renal failure patient, linagliptin is drug of choice. If it is, that means drug of choice means they do not require dose adjustment in liver or renal failure patient. But other gliptins better to be given in better to be avoided or given in a very low dose. Adverse drug reaction, nasopharyngitis is a common adverse effect of sitagliptin or other gliptins. Apart from that, we have to take care of, we have to take history of the pancreatitis. So sitagliptins, vildagliptin also there. So their metabolism is mostly hepatic. Also, sitagliptin can cause some renal, has some renal excretion also. So they need to be given in lower dose in hepatic or renal failure patient. And so that's why linagliptin is more advantageous. Also, a newer agent is there, linagliptin. This is a very low cost gliptin. It is invented in Japan first, but nowadays it came into market in India. It is not present in your textbook, but it is very well tolerated drug and also very good, highly efficacious drug, linagliptin. So I am stopping here. SGLT2 inhibitors will be discussed in next class because it is getting too lengthy. So just for the name is SGLT2 inhibitors, canagliflozin, dapagliflozin and empagliflozin. These are the three major SGLT2 inhibitors that will decrease the, how they act, they inhibit the proximal tubular reabsorption of the glucose, which is where SGLT2 receptors are transporter are present. So thus they cause more glucose excretion, decrease glucose reabsorption. Thus they decrease the glucose load in our body and cause very effective control of the blood glucose.